so welcome to session 2 of the roundtable today. I think session 1 we did a good job of looking at some of the basic issues and contextualizing it for an Indian socio-political context in terms of healthcare and AI. And in this second session, hopefully we'll try to complicate some of these ideas that have already come up, and let's try to see some specific examples and case studies and see newer perspectives that will hopefully come up. So we have 3 speakers for the session. Before that, I'll just quickly introduce myself. I'm Radhika Radhakrishnan. I'm a policy officer at the Center for Internet and Society, and I am a trained computer science engineer as well as a general studies scholar. So I look at the regulation of artificial intelligence in India from feminist perspectives, and hopefully we will have some of those coming up during the session 2 today. So we have 3 speakers for this session, and we'll have 20 minutes per speaker, and then we can keep the discussion at the end of the 3 speakers the way we did for session 1. So let's also try to stick to the time in the best manner possible. And so for speaker 1 today we have Dr. Surajit Nandi. Dr. Surajit was trained in internal medicine at the Massachusetts General Hospital in Boston and did a fellowship at the Center of Brain Science at Harvard. And he also has a MPH from the Harvard School of Public Health. He holds an MD and PhD from the Washington University in St. Louis, Duke University, where he worked on deep learning in computational neuroscience. Surajit founded Raksa, a health information company based in Delhi with the goal of providing good healthcare for all. Dr. Surajit, we can...
Thanks for inviting me. This is the first time I realized what a boardroom actually means. It actually has boards, but So I want to talk a little bit about, as the chair was saying, I spent a lot of time in America, and then I moved back to India about 10 years ago. And I'll tell you about sort of an adventure or a journey through the health space and what it's become. And essentially what happened is that I worked in underserved areas as a doctor in slums of Delhi, rural Chhattisgarh, and all. And what I found is that we would see 500 patients a day, and the problem was that at the end of that day there'd be another 500 patients that we would have to turn away. And this sort of highlights one of the major problems in India, which I think Health AI has a lot to say about, which is meeting the gaps between supply and demand. So let me tell you a little bit about our adventure through it with the organization that we call Raksa, and I'll give you 2 case studies about how that has gone, and pose a couple of ethical quandaries that have come up along the way. So everyone can hear me, right? So Hippocrates says that wherever the art of medicine is loved, there is also a love for humanity. And you may think, therefore, that humanity is essential to practice medicine. But the problem is that software is eating the world. And as Shivram said earlier, I think it's very hard to define artificial intelligence. You might actually say that artificial intelligence is something like Clippy, if those of you who remember what Microsoft Word was. It may just be something like a phone. It may be the ability to do 2 plus 2 on a calculator. That's artificial intelligence too. But I think what we are calling artificial intelligence is the replacement of cognition at what we think of as the decision-making part of the systems of the world. So we make decisions as doctors about clinical issues, and those things are starting to be addressed by software. And I think that's the AI that we're talking about. And maybe that's the difference between what you were asking, between digitization of data and it's actually decision making is happening. So India has a supply problem. This is hard to show up here, but I think most people know this. 1 in 300 people in the US is a doctor. About 1 in 1,700 people in India is a doctor. So we have a automatic shortfall of about 6x. That's exceeded in parts of sub-Saharan Africa as well. So we're not the worst off, but certainly in most rural areas and in some of the underserved states, our ratios of supply to demand are very, very low and approach the lowest in the world. So India has a supply problem. This is not getting better anytime soon. It's not going to be fixed in our lifetimes. So when I sit as a doctor and I have 500 people that I turn away, that's not going to be served by creating more doctors, creating more human resources. What we found at Raxa on the basis of was the idea that the only thing that can scale is computers. Algorithms that can be put into people's hands, and I'll tell you about 2 examples of that in following. So let's start with the case. This is and this sort of highlights why India is a very different situation. So the AI that's generated in the US and other developed countries will not obviously apply to India. And I think that's an important distinction to be made in the times to come. So imagine a 19-year-old boy who comes to you who has a bout of rheumatic fever. Now rheumatic fever is a fairly simple illness, but it has bad sequelae. So you might scar your valves of your heart, and that can cause, in the worst case, death. So how do we ensure that this boy does not develop rheumatic heart disease, which is a sequelae of that rheumatic fever? So in a developed country, the standard of care is you give that boy bi-weekly, lifelong injections of benzodiazepine, right, for the rest of their life, to stop them getting another episode of rheumatic fever. This is too expensive and too inefficient in India. The de facto standard of care in India is actually, this is not the law or the state policy. You let people develop rheumatic heart disease, and those who are symptomatic, those who cannot walk more than say 10 meters, those who face death often, those just treat them. That turns out to be a less expensive and a more cost-effective approach to the problem. It's probably bad for the quality of life of some of those people who have rheumatic heart disease, but if they're not dying, it's better for them and better for the country, since we're such a poor country, to not treat them with penicillin. I am, every week for the rest of my life. So that's what you do. So this is to highlight that the epidemiology and the treatment options in India are going to be very different. So any AI that decides to do something in India is going to be fundamentally different than the AIs that are developed in the developed world, where, as Navneet pointed out, so much of the investment and activity is going on. So I'll start with the first case study. Surgery, almost everyone in the world has a major surgery at some point in their lives. Surgical complications are a very big part of it. Some of the lowest complications are around 3%, and they go up to about 54% for some of the more complicated surgeries. And what this shows on the left side is that you can actually divide surgical complications into grades, right? So number 1 is the least, you didn't really have a bad complication. Number 5 is the worst, that you had death. So that shows you the sort of the histogram that most of the complications that happen are on the right side, in the right panel, are relatively small complications. Now, what's obvious about surgical complications is that humans can classify these. So a surgeon will be able to say this patient has had a complication, and we can call it a 1 to 5 in this particular scale, Clavind-Dindos scale. We can say that this person had this classification. So we asked the question. We have a platform that some surgeons use. So we took some of their data and asked the question: can a computer do this as well? And so the data that we have is just this. So surgeons use our platform and they put in text data, which is, like the patient showed up, their urine output was X, they was like 100 milliliters, they were febrile, and they just type in text, and sometimes they put in some images. And we took that data and we did some of the things that Shivram talked about. We did natural language processing and took this unstructured data and converted it and started doing deep learning on it. And asked the question, can that learning predict which patients will have surgical complications? Now, this graph, again, it's hard to show, but basically, if you look at the upper left panel, on the x-axis, on all of these graphs, on the x-axis is the post-operative day, and on the y-axis is the severity of the prediction by our algorithm, right? Just based on these data. And what you can see is that the label, so we asked expert surgeons to label the patient's course and ask whether they had a bad complication or a good complication or not. The label corresponds to what the algorithm predicts. So for example, on the bottom right, that patient actually died. And you can see that the graph starts low but then goes up high, right? So that means that the prediction of our algorithm that the complication rate was likely was very high. In the on the top line, you can see a lot of patients who actually did fairly well. So the first patient on the upper left was doing badly, but then started doing well after that. And then other patients, in the top line, they started out low and they did well. And as you might predict, the labels applied by expert humans were actually exactly the same. And this is a confusion matrix. If you look at the real labels on the y-axis and what our algorithm predicted on the x-axis, you see that while it's not perfect, our algorithms can predict with a fair amount of accuracy of about 84%, 90% at 15 days, when you've got 15 days worth of data, what complications the patients are going to suffer. Now this compares favorably with what humans can do. So these are the correct answers from surgeons from Japan and some other developed countries, USA, Switzerland, so on and so forth. And you find that they range somewhere between the high 80s to the low 90s. And our algorithms are getting pretty close to that already, and this was on a fairly small subset of data. We're extending this to larger data sets. The problem with this, and why I'm bringing this up in an ethics conference, is that what you do with this. Now, we as the platform, we know something that the surgeons may not know. Certainly some surgeons may not know. Should we tell them? On our platform, patients have access to the data too. Should we tell our patients that you are likely to suffer a surgical complication? So, we have, I'm sorry this is not showing up so well, but we have a platform that all of you use Amazon. So our platform mimics that a little bit, which it says, so if a provider is seeing a patient and is putting in data, the platform will be able to look at all the other patients on the platform and give recommendations to the patient that the provider is actually saying that other patients on the platform have suffered, who are similar to this patient, have suffered with this diagnosis. Please consider this diagnosis. This is something that's fairly easy to do for any decent classifier. What's worrisome is that we can actually, in that right panel on the platform, deliver that graph itself, which is that we predict that for the first few post-operative days, your complication likelihood is low, but for that last one, it has just gone up significantly, above our threshold. We've had a real ethical problem with this. it's a quandary. Should we show our providers this graph? Should we ping the patients and their relatives with that graph? And up to this point, we haven't been able to decide that. And as Dr. Bhan was talking about earlier, we'd love to have an ethical framework to decide how or whether we should do it. I don't think there is one in the world. Another thing that we do is that, as was talked about, machine learning is never going to be something that defines everything. To presume that machine learning will be able to recapitulate all knowledge and all intelligence in the world would be to presume that you can rerun evolution as a simulation for the billions of years of existence, and also the simulation of all the environments. Right? It's not the case that de novo we're going to be able to generate medical insight just from medical data. There's a whole bunch of other stuff that's gone into it that we're going to need. So one way of getting there is, as is done in self-driving cars, as was talked about earlier, you can use human knowledge to actually seed the machine learning as well. So we do that as well, and we use medical practitioners to seed our AI to give diagnosis and therapy recommendations. Here's an example of some of the knowledge strings, if you will, that they come up with in, say, the domain of acute chest pain, where people talk about all the different categories of acute chest pain and what can be done about them. Right? And so our machines are able to apply those recommendations to data. What you see here is in a bunch of different languages. In the left panel, the patient is showing up with a systolic blood pressure of 180, and the system is actually recommending that the patient be prescribed a drug called enalapril, which is an ACE inhibitor, those of you who are medically trained. But the middle panel is being prescribed with the same presentation, is being prescribed amlodipine. That's only because the patients are different, their past histories are different, and the set of patients around them in sort of data space is also different. So we can change our recommendations based on that, seeded by human knowledge. Now, this creates another ethical quandary. This is from this idea of a moral machine. I don't know if some of you have come across this. This is often brought up in self-driving cars. That if a self-driving car was going in and there was a baby crossing the road and a grandma, and you had to hit one of them, which should the self-driving car hit? And this was published in Nature recently by MIT Media Lab, and they found that individualistic countries will choose the grandma, and countries like ours will choose the baby. To run over. But a version of this ethical quandary is in our recommendation system, our clinical decision support system. If you're going to recommend to people to do something, to do A versus B, right? Now you have some utility function, some way of deciding which recommendation is better. But what if you don't really know? And what if the person's living or dying is based on the practitioner taking one decision support recommendation versus the other? What do you do? And this is something that comes up for us as well. What if we get it wrong? So here's a self-driving car. It has to hit one of two things: an unattended baby carriage or an unattended shopping cart. Now you'll obviously choose a shopping cart. But actually in computer vision, and the computer scientists here will know this is a very hard problem to solve. To decide that because a shopping cart may have a baby in it too. Right? So you can't just classify it as a shopping cart. The baby carriage may not have a baby in it. So these are very hard hard problems that self-driving cars will have to deal with. This is to underline the fact that while AI promises a lot, and this is the era, if you will, for AI promise, and things from self-driving cars to help, it's a long way away for us to get any autonomous decision-making process making, replacing the highest point of the decision making in a system. So artificial intelligence, if it's defined as a thing that takes away decision making from humans at the very top, decision making, say, in clinical practice, I believe, is a long way away. Ethics is hard, and what we do, our answer to the question that I posed, Dr. Khan, is that we test. We show people things like the graph that I showed. We show people things like the clinical decision support things, like what patients are like this patient, what was done for this patient, what are other diagnoses that you should consider. And sometimes some users like it and some users don't. So we use that to guide it rather than a pre-existing ethical. So that's it. Thank you.
So our next speaker for this session is Ashish Srivastava. Ashish heads the Digital and Artificial Intelligence Lab for Se-2, which is a technology and policy think tank headquartered in Bangalore. Ashish has 30 years of intense career in the IT industry, where he has handled diverse and challenging roles. He started his career as a network engineer and subsequently as a leader, managed global IT businesses, directed large complex programs, and even headed an IT product company. On the technical front, he is considered an adept enterprise architect and solution designer. He has personally led large initiatives involving various digital technologies, including state-of-the-art technologies like AI and IoT. His current focus is towards creating solutions for socially relevant areas like health, child welfare, agriculture, and defense, using advanced technologies like AI. Him and his team were recently declared winners of the IDEX Startup Challenge by the Department of Defense and NITI Aayog for their proposal on AI enablement of defense logistics. Ashish has done his BTech from IIT BHU and Masters from IIIT Bangalore with a gold medal, and he also holds a postgraduate certification in economics from University of London. We're happy to have you here, Ashish.
So while the picture comes up on the screen, first of all, thanks for this opportunity, all of you. What the main idea of this case study is to present a different perspective, which I believe we often miss out. So it's more than the case study. See, whenever we discuss an AI, everybody is discussing. So that's one of those things. Even if you take the triple helix model, the government, the academia, and industry all are deep into the whole consideration. One stakeholder which is getting less attention in terms of the viewpoint are the people, and there are less of those numbers anyway, who have to take these solutions to the masses and implement at the scale. So they are the people who have to stitch a solution for a social problem and then deploy it. So, and then you will realize that probably we sometimes, while AI definitely is a path-breaking technology, but just like many other technologies, we probably are giving too much primacy to it. Because there are a lot of things that have to happen while you stitch a solution before, and Shurjit was rightly pointing out, it's about what the doctor should do, and so technology is thing, but you have to sort those things out. So through this narrative, I think, please take it in the right spirit, it is an attempt to point out some of those challenges. Very quick view of Se-2, will not spend time. We are a not-for-profit think tank, very reputed in energy, climate, and environment studies. Have completed 10 years. We have been into policies and all the stuff. And last 2 years, we have been heavily investing and implementing the e-governance and governance solutions in the case, for example, in urban, in healthcare, in pollution, those kind of things. Today we will go through a case study of malnutrition management, the way we did in, say, Karnataka. Okay, now malnutrition is a very, very complex problem for people who have seen the data. I mean, across India, the number of stunted children is 39%. That means 39 children out of every 100 actually is stunted. And when you are physically stunted, you are also mentally stunted for life. There is a high correlation to that. So that's a very high number. And we don't see stunted children around us. That means it all goes back to the lower strata of the society. That means 50-60% is mind-bogglingly high, how high that number can be. Same thing with the mothers, and I will not go to each number. 50% of the pregnant women across the board are anemic. Very high number if you go to the villages and remote areas. 60-70% of pregnant women are anemic, and that has a cascading, if they are severely anemic, it has a cascading impact on the fetal health, and then that means the child will be born unhealthy, and that is how it is. So it's a very, very big problem in India. Improvements and attempts are there, but I think the goalpost is far away. So one model which we tried to understand when we got into it, whether there's a concept of wicked problem, okay? It is not a solution, it is just a framework to understand the problem. Wicked problem is a formal term, okay? There is a definition to it, we will not want to it, but it's a complex problem. You don't know where to start, where to end, how much to do. 39 becomes 15, is that good, or it should become 5, it is good, you cannot do that. Which problem to attack, which to leave. So even if we try to do the causal analysis, there are operational causes, the way the healthcare of a child and mother works. That itself, there is a lot of problem there. Then there are behavioral causes. The hygiene, the way hygiene is kept in the house, the awareness of the woman who is tending to the child, the domestic attitude towards helping the mother, all those things are behavioral issues. You can do something about the operational causes and the behavioral causes. Maybe technology can help. Then comes the more basic socioeconomic causes. There is no land, there is no food in the house, okay? There is no education. So how do you do that? Can technology help? Possibly, but it will be very obtuse and indirect way of doing that. So this was just a way of understanding of where we should focus as a technology if we have to address this problem. And we decided we'll first tackle operational causes with facilitation towards behavioral, and then probably see if we can at all contribute to the basic causes, because that is not a technology issue. If you solve the world hunger, then anyway every other problem will get solved. It is like that. So how do you approach from the technology perspective? That was a question that we asked ourselves. So one of the frameworks, and I'm an IIT guy for 30 years, okay, but solutions guy, not component, or though I have done all that work. But when you look at a solution, you have to look at a framework. And we resorted to system thinking because I personally like it, okay. Because what it does, okay, and this is from the Reynolds and Holwell paper, who were good exponents of that instead of thinking about systems, sometimes I feel that when you start from a technology, you are putting the cart before the horse. You have to approach the system thinking where you nail down the problem first. And that's why the holism, that means the broad context. Pluralism means that, if you comparison is the forest and the trees, you have to understand the forest and you have to understand the context of the trees within that forest. Unless you do that, you don't understand what the problem is. And then once you have done that, you have to identify the stakeholders, what is the relationship, what is the situation, and all that is important because the politics and ethics also lies in that particular last bracket. In fact, in the system thinking approach, I like this quote a lot, which is very old by an exponent on the systems methodology. That a systems approach begins when first you see the world through the eyes of another. Okay? And sometimes as technologists, and myself as a technologist, I'm guilty often of that, is that we are too arrogant in our things, and what sociologists will call technology deterministic. I have a technology, I will solve the problems of the world. So that is what we have to avoid, which we eventually did. We did a thorough action research across multitude of, we went to Anganwadi centers, primary healthcare centers, sub-center, tertiary, talked to even the helper, we talked to dozens and dozens of them, to really nail down where the problem lies, and to the tertiary hospital doctors who had their point of view in terms of where the challenges are, before we said we will jump into creating a solution. And after all that study, we realized that there are 4 big problems. There were multitude, I will not go through the list of it, but one is that, and it is substantiated by papers and the general observation, it is intergenerational. Mother health is as important as a child's, but if you look at the systems which are around, mother's health is not given the centrality. All the measurements, even some of the recent reports which I saw, which NITI on the health, mother's health is not given the same centrality as the child health is given in terms of stunting, wasting, etc. So that is one thing that we realized was happening. Second thing is it is multi-sectoral. The way it works, today Mother and Child services are offered by Women and Child Development Ministry, which has its own department. Health has many departments which come into picture: health and family, the primary healthcare center ecosystem, and then you have the tertiary hospital ecosystem. The child care passes through all these steps, and there is no linkage between them. So forget about technology. I'm not talking about technology. A child is detected through his weight and height as being severely malnourished in the Anganwadi. He is referred to the PHC. There's no clue to anybody what happened to that child. Whether he went to PHC, the parents took him, not took him, there's no clue. When he comes back also, what prescription was given, not known. When tertiary hospital, the doctors got emotional because in tertiary and nutrition rehabilitation center, what they call, there are 16-bed, 20-bed hospitals for severely acute malnourished. And there is so much positive beds. The moment child shows 3 days of improvement, he's released. He's not cured, by the way, in complex cases when the child goes. They say, I have no clue when he's handed back to the community what happened to the child. Relapsed, survived, not survived, don't know anything. I would want to follow up, have no way. Health data across all these departments, non-consistent. You pick up the immunization record from a WCD and from the health, doesn't match. Family data doesn't match. Women data doesn't match. Not, and we went through source data. And last but not the least, field workers are the last single point of failure in this one. They are the ASHA, the auxiliary nurse and midwife, A&M, and the Anganwadi worker are the last point of failure. But no app is being done for their needs. Yes, register automation apps are there, data entry apps are there, and bells and whistles around that, but nobody is taking care of that. So we said, now this gives us a good design principle of what the technology should look like. So then we set up a goal for ourselves. This is more like our design principles, that we will not let a woman falter in nutrition due to inadequate access and support. And I'll give you an example of it. That in Karnataka, where we are working, for antenatal checkup when she is pregnant, she typically goes in villages to the sub-center, okay, where the A&M is there, sometimes primary healthcare center, if that is near. There are 9,500 approximate numbers, sub-centers, and there are 2,500. About 12,000 these centers are there. Most of the bulk of the women go for the antenatal checkup, which is so important. Anganwadi centers are 67,000. Now, the A&M, who is the main person who does most of the checkups, except for the first one where the SLID doctor is also involved, she comes anyway to Anganwadi center every month, at least once, if not twice, to give immunization. Why can't she also do an antenatal checkup there? Because if you can do that, you have increased the access of the woman 6 times, just like that. So those kind of things come when you think of women. Again, the tracking through the multiple departments of child. Field workers should not feel that they are without support. No, but they kept on repeating. If I have a problem, my toilet is broken of the Anganwadi center, water is not there, electricity is not there. There was Anganwadi, 5 days there was no electricity. It's like, whom to go? How much to follow? There is no way to do that. And enable the administration and the policymakers who are also hindered by the lack of actionable insights. So this became and then our solution started to emerge. We set up, and mind you, we are still not on technology. We worked with all the departments in the Karnataka state, and we set up first a unique identification process for every child. We said only one ID. No matter which department you go to, child will be identified, mother will be identified, and family will be identified only through these unique IDs. We said we will link all the systems together so that the data, so that means ownership of the data has to be identified, and how it has to be shared and who has to have access has to be identified. We fixed that problem. What will be owned by health, what will be owned by hospital, what will be owned by the Anganwadi. Complementary resources, I talked about, can A&M come to the Anganwadi center and do A&M? How can that asset be shared as an Anganwadi center? So we sorted out as a policy across the state department, and then integrate processes. Now we said that now everything is there. Can we agree that if the referral goes from the Anganwadi center to primary healthcare center and primary to the tertiary center, can that tracking be now be done, because you have put in place the fundamental structure, and referral and the back prescription when the child is handed back to the community can be managed. All these things were first sorted out, agreed between the multiple departments, and then we said, now is the time now to bring technology. Okay, and technology also, we didn't move to the AI immediately. We first conceptualized and made this available. Now, app is not important, okay, because there are other apps which are also very good, and central government is also positioning some of them. Absolutely fine with that. But so app is only one component. It is multi-sectoral process integration which sits behind it, the data integrity that sits behind it, and the inclusivity of the people. There is a component in the app which is all about how an Anganwadi worker or an ASHA worker can raise their request, do a follow-up on that particular thing. If something is, when we went and showed them, they were very happy because the inputs were from them only. But they say, add one more, please. We sometimes don't get salary in time. Can I raise that request? So we added that, by the way. So then that took the shape of the first application. So this is, and then there are a host of things I will not cover in the interest of time. It has all the bells and whistles, how you can see how an Anganwadi can feel empowered about the whole thing. One good thing is that when she comes every day, can this app in an intelligent way make her day's calendar? That these 3 children are the most needy, you have to refer them, that guy did not go to the PSC for 2 weeks, can you chase? So all that is done automatically, which was needed by them. So all these things have been done. Now comes about AI, because we are sitting here talking about AI, so somewhere it has to come. But it has to come in the proper context. And you remember we talked about this wicked problem, and this diagram was there earlier. What we have done is data integrity, process inclusivity. But what we have to do more? Now we know the context. One thing after all this, evidence of service is still lacking. Whether the actual service provider, whether the actually height was taken, weight was taken or not, the service was provided or not. Then, because if that was not done and the number put in the app is hypothetical, then nothing else is going to work. So how to do that? Accuracy. We found repeatedly that the way height is measured, it leaves a lot of room for inaccuracy. Stunting, by the way, happens most when the child is less than 2 years, and then only it is reversible. If he is crossed 2 years, it becomes almost near about irreversible, though some studies will point out that it's possible to do that. So if the child taking the length of the child, they don't call it height, it requires 2 people. Most of the Anganwadi centers don't have a helper, because one person has to hold the child straight, the other person takes the measurement. Now, and that's why it is never taken accurately. So accuracy is so important. Now that's where can AI help? Actionable insights and predictive. The moment the child, because there is a variation of region, community, religion, caste, so many things which can be used to predict upfront whether the child is going to have a risk of malnutrition or not. Can AI help in that? So that's where we actually brought the AI. Now we are almost complete and we will integrate it. It's coming at very high accuracy. You take the children's height, which is by taking a mobile photograph. It's not a very complicated algorithm. We are using existing computer visioning because it had to be easy and simple. And it has to work in an Anganwadi context. Anganwadi worker only has to take the thing, because we got a feedback that a correct view is to take from 3 angles and all that stuff. We said it will not work. Because the first time when we got to the Anganwadi, he said, I cannot even take every child's photograph because I have 40 children who come here. Can I take photographs in groups? So we worked on that. So that's what the inclusive design is all about. We said, okay, 5 children, because edge detection can do that. Face recognition can happen. There are existing algorithms for that. So we made all that thing. Problem is then when the skew is high, when the wall is dirty and noisy, the condition sometimes it's failing. That's why we have not implemented it yet. But those things are just a matter of technology cleanup. Will happen. Attendance is based 15-20 minutes, and again it lacks evidence because she can mark anybody attendance. Take a photograph, saves times for us. Her convenience, and it's accurate. Face recognition. Problem, when the child is very small, okay, then face changes very fast. Okay, so reference photograph now. So we are now every day's attendance, we make the reference photograph that day's attendance. So we are working on that kind of thing. So it gradually the reference also keeps changing. It's a moving target. And then we are building, because now one thing I missed that as part of the process integration and all, there was both the departments do their individual family surveys. 80% of the questions are demographic in nature, both do, and never matches. If you only focus on a technology-driven point solution, by the way, they are very important, because if they are not there, how will you actually end up stitching the entire solution? There is a difference between a component and there is a difference between the solution. Second is ensure that the road is there before launching the car. And I have a feeling, and not everybody is guilty of it, that everybody is saying that here is a BMW, I will solve the transport problem of the villages with that. But there is no road there. Who is going to build that road? You You can't land a jet when there is no runway. So somebody has to build the road, and that particular stakeholder is missing. That's what this voice in the session was all about. Third is focus on the need of the driver and not just the passenger. Who are the grassroots workers who are, and mind you again, whether I read that paper or some other report about IBM Watson's not being able to meet the expectation. One of the things that doctors are not ready to accept that particular solution for various reasons. And my feeling is that they have not been factored in as a process. This system, whatever IBM Watson was doing, I am getting a feeling that how it blends into a hospital process was not well thought of. Okay, enough thing. And then when you make it for ready adoption, you have to do that study, you have to launch pad it properly. All that was not done. You bring it something from the lab and say, here is what will solve your problem. Will never work. So that is on the needs of the driver, which is doctor, field workers, grassroots workers. And last but not least is know the destination. Purposeful AI. Only after we cross the 3 or 4 hurdles, we exactly knew that it is not hi-fi disease detection through the face or something that will cause a problem. Here are the 3-4 things which you do, your 90% of the problems are solved. So that is what the purposeful AI, which I always canvas for. And clarity on which means clarity on the precise need, what is the context, who will be the user, and where it fits into the larger ecosystem. That is very important. Once we have done that, then I think we'll be there. And that is what is little bit lacking in terms of discourse that is happening around, because we talk about the technology, we talk about the sectoral and the domain knowledge, we don't talk about how this kind of projects should be implemented on the ground so that they can produce the right outcome. We'll end up with a caveat that this is a concept solution with multiple departments in the government of Karnataka are supporting financially and in terms of every other support. And it is not an app, so it should not be think. It is a solution for multi-sectoral governance, for data integration, all that stuff that we are trying to do that. And that's where it is right now. Thanks a lot.
We have our last speaker for this session, Ashwini Kalatri. Dr. Ashwini is an assistant professor of community medicine at MGIMS, where he obtained his MD in 2015. He currently leads the hospital management information system developed at the Kasturba Hospital. He's also in charge of the Rural Health Training Center at EPD. His interests lie at the intersection of technology and healthcare. He dreams of a system that is able to harness the power of technology and at the same time being invisible to the end user. A system that truly simplifies work processes. We can hear from you now, Dr. Ashwini.
From what I've heard since morning, from discussions that I've had on tea, a lot of this has already been discussed. A lot of this has already been there in the minds of people here. So I'll probably not need the time that I was allotted. I will skip through slides, go faster, and give you my views, my ideas, my thoughts on what I felt are the scopes of artificial intelligence in public health, and what challenges I feel artificial intelligence faces when it comes to implementation in public health scenarios. Right. So, the Indian public health system is a 3-tiered system, where there is a primary health care setting where you have community sub-centers, primary health centers. You have a second tier, you have community health centers, rural hospitals, and then you have tertiary centers, that is district hospitals or medical colleges. But the problem here is a lot of data lying in these systems is still on papers, is not digitized. So when we speak of AI, the ingredients for AI are not readily available. There is a lot of push over the last couple of years to digitizing these systems, to ensuring that this medical data, their workflows are available in digital formats. The IT infrastructure has slowly started coming in. There is internet connectivity in most primary health care centers. With the advent of mobile internet, it has crept in even more now. And finally, when we dream, some surveys say that AI has a potential to save healthcare costs. They say that in the US, it might save as much as $150 billion over the next 8 years every year. Right? So here are a couple of scenarios that I felt AI could help in public health. One of the biggest place where it can help is our public health programs. So the Ministry of Health and Family Welfare runs an array of programs for every disease that you think is possible. You have a program for HIV, for TB, for malaria, and you have a specific data collection system for every program that there is. So these are all vertical programs, separate programs. They do not link with each other. So an example that I take here is RNTCP, that is the Revised National Tuberculosis Control Program that aims at trying to control this mammoth problem of tuberculosis in the country, and it uses a software called NICSCHE, which collects an array of data. It collects who the patients are, they register them, they follow them up, whether their sputums were positive, whether they were taking drugs, whether they were not taking drugs, whether they developed drug resistance, and how many of them got cured, how many of them died, and all sorts of indicators are available in this system. Now, this system is already in place and helps the government to run this program smoothly and see where it is progressing. But then these systems across all programs do not help the providers to deliver the system, right? So couple of places in RNTCP where artificial intelligence could help is one is active case finding. So program stresses strongly on trying to detect more than 85% of all tuberculosis cases in the country, and it does that by screening a lot of patients and then detecting most tuberculosis cases. So is it a possibility that artificial intelligence, by trying to harness data mined from social media, from other sources, is able to pinpoint tuberculosis cases and thus reduce cost, effort of the national program? Microscopy is one of the forte where we ensure that the tuberculosis case is caught and the treatment is started. So there is a technician sitting at every microscopy center who would be seeing tens of slides every day. He will see hundreds of fields in every slide every day, trying to detect the tuberculosis bacilli. At the end of the day, if you expect quality from him, it is not possible. The manual fatigue that you will get after seeing so many slides and so many fields is obvious. And again, I think this is an easy application of AI where a photograph of the slide is able to detect what category of tuberculosis this person has and how much of an infection he has. And finally, a big problem that we face even today, we try to solve it by categorizing patients in weight bands, by sex, by age. But again, there are certain categories, and that category will receive certain treatment. You do not customize treatment even today for tuberculosis. Is it possible, like we've discussed in certain scenarios by other presenters today, that you discussed where one patient with similar background received a different hypertensive drug as compared to another patient because they were inherently different. So can that happen here for tuberculosis also? So this was tuberculosis. Same can hold true for HIV, for malaria, and so on. Outbreak prediction. One of the major work that a public health system will do is to predict outbreaks, try and stop outbreaks, and then investigate why they happened. So again, we have examples where models were able to predict, model, and then slow down the spread of diseases based on AI interventions. Philippines was able to correlate data, their old data from 2019 and 2014, and the weather data, and was able able to find that the dengue risk increases when there is during a certain period after rainfall. When the weather conditions change, then that lag will change. So all sorts of correlations with weather data, with and with the outbreak of dengue. They were also able to create heat maps that would predict when a dengue outbreak will happen in a particular area of the country, right? And again, they have moved to the next step where the researchers were able to prove that yes, this system works, and now they have started working with the government to integrate it with the surveillance system and actively use it to prevent outbreaks and to predict outbreaks. Decision making, again, I think I missed the April 2019 article which says that Watson didn't really work. But again, as all of us have already heard here, that there's a big dearth of doctors in the country. The ratio of patients to doctors is abysmally low. And this is even more skewed when you look at remote locations, rural areas, where you have very few doctors to the number of people, the population. The doctors that actually do go into rural areas or actually do serve the PHCs are fresh medical doctors who are inexperienced, who have little clinical exposure, and they have overwhelmingly extra responsibilities as compared to what just the medical doctor would do in a hospital. They have administrative responsibilities, managerial responsibilities. They have to manage the supply chain. They have to ensure that the programs that the government is delivering are properly delivered. And combining all of this together, they are also supposed to ensure that the medical health of the area that they serve is looked after. So again, Watson tried to do that. What it did was it correlated medical literature, journals, textbooks, and then also the patient findings, and then predicted whether this patient needed treatment, what was the prognosis, and how he should be treated. The clinical decisions that a doctor needs to make were handled by the AI system. And I think it is not ready today, but maybe a couple of years down the line, the load for the doctors at resource-limited settings may be taken over by some degree by AI. Again, a lot of the roles that these doctors have are non-medical responsibilities, managing immunizations, planning them, making sure that there is coverage, ensuring that there is stocks of drugs, vaccines, that the supply chains do not break, the cold chains do not break. Where should I refer? Should I refer this patient? Should I refer him to a tertiary care center or just to my next secondary care center? So all of these decisions can be made with the help of an AI system where they ensure that this load on this sole doctor at a tertiary or a remote area gets shared. Now, this is something that I really want to think aloud. So medical science expands, it grows by doing research. We try and do experiments, and most of these experiments are human experiments. And by being human experiments, they have those ethical limitations, right? So I cannot do just about everything that I want on a human being. That happened years ago, but that is something that nobody does today. But then those limitations also limit what a research can produce and what the outcomes are. So is it possible for AI to mine data, to harness data, and then finally produce results that are faster, more efficient, and probably more accurate? This is something that I do not know. This is something that I would like to loudly think. And once they fill that in, they would also be questioned as to why those indicators are bad, why were there maternal deaths, why was there malnutrition, why was there anemia, why were there diseases. And to escape from these questions, from the pressure from top, this data gets manipulated at every level. So the A&M, the ASHA would probably increase the weights of their children. The medical officers would probably not report certain diseases, and this slowly gets accentuated, and the data is absolutely garbage. So this happens at the A&M level, the PHC level, the district level, and probably also at the state level, where everybody wants to portray that we are doing great work and we are slowly improving from what we were before. And then when we have data of this sort coming in from the public health system, how do we use this data to build any model for AI? Will that model achieve the goals that we seek to achieve? Ethics has been discussed in depth here. I think there are more presentations that would like to discuss ethics. So again, do we use AI to detect diseases? If we do detect diseases, you have certain ethical issues. Do we tell the doctor? Do we tell the patient? So what happens if in the future you search for fever and Google tells you, by the way, you also probably have lung cancer? What do you do then? Is that something that you would want? Is that a place that we are going to? It is something that we need to discuss. Jobs is something that often gets talked about when technology comes in the picture. When AI comes in, do people lose jobs? And this is something that has happened multiple times in the history. There were industrial revolutions, there were digital revolutions where the jobs that people used to do would get replaced by something that a machine would do or a computer would do, and probably now that AI may do. But then that doesn't mean that these people go useless. Their jobs get skilled. These jobs change into something that is more meaningful. They stop doing laborious, repetitive tasks, and they do something that is probably fitting to a human intellect. And the level of jobs will increase. So these jobs will get compensated by new jobs. The final thing that I want to talk about is there are two people in the picture when we talk about AI in healthcare. There are doctors and then there are engineers. And these are two very different people. These are two people who speak absolutely different languages and they do not understand each other. So again, a lot of us have talked about how do we bridge that gap, how do we walk over to the other side, and probably doctors learn a bit of technology, technologists, engineers learn a bit of medicine. I know it's a difficult scenario, but then we do need to start a conversation. We do need to understand the respective fields for AI to grow. Thank you so much.
Thank you so much, Dr. Ashwini. So I think throughout the session what we've had is we've heard a lot of case studies and solutions for a lot of the issues we discussed in the morning, and what I'm going to do now is like zoom out a bit from these solutions and pick out on some interesting strands that I thought were commonly discussed across the speakers, and then we'll open it up hopefully as starting points for discussion and hear further thoughts from others as well. So one thing that we've been hearing since morning is that India has a supply problem, right? India has a supply problem of doctors, and therefore AI has been pitched as, in a way, a solution to this scarcity problem. So the way I want to pose this question is, and we also heard Dr. Surajit talk about how therefore technology and AI is a scalable solution in this sense. So the question I want to pose is not in the sense about whether technology can solve these problems, but also whether technology should be tackling these problems in certain ways. So the technology determinism, for example, that you also spoke about, it's an important context, it's an important question in the Indian context, because all the Indian policy narratives also have this one component of, AI for social good. So there's a certain understanding that there's a need on the ground, and these experts, expert doctors, expert engineers are going to sit here and tell what these solutions should be. And a lot of my fieldwork has involved going to these rural areas and seeing how the bodies of essentially what happens to be the underserved populations of the country become testing grounds for a lot of these technologies, especially AI, because AI is a technology, unlike other technologies, where you need the algorithm to learn based on existing data to find patterns, and the people's medical records that get used for this basically belong to a certain caste, class, gender. So the questions that we can be asking in that context then is, what is this technology really replacing, and why are there not enough doctors sitting at PHCs? And therefore, the solutions that we think of are going to be tailored to the way we frame that problem in the first sense. So what kinds of experimentation, exploitation is taking place in the process of building these scalable solutions? And as Dr. Ashwini also pointed out about medical experimentation, etc. The second, and these are urgent questions also, because as Virginia Eubanks also talks about, how the moment a system becomes, the moment you scale up a system, it becomes that much harder to decommission. So think about how hard it's going to be to decommission a Google infrastructure, for example. So these are questions we should be asking early on at this stage. And that's another interesting thing that I thought was a part of the Sneha program also, because it seemed to be arising from the ground up needs of what the people were going through, keeping in mind those realities, which is not really observed in many of the existing solutions, which aren't necessarily need based, but also like glamorous technology solutions, that the state wants to be seen as a technological state with a lot of advanced science and technology, and whether that really benefits the people that we're saying we're having these solutions for in the first place. And the last thing I want to flag off is the interesting examples in terms of the ethical dilemmas that we were discussing, is just how AI forces us to actually then think about these questions as a society, which means questions about, in the instance of the self-driving cars, whether we say the old woman or the child also reflects what we think about children and women in society. So these are not necessarily technical questions, and that's also where the ethics perspective comes in, which is that these questions are ethical questions, moral questions. They require public debate and conversations from multiple stakeholders across interdisciplinary backgrounds. So the thing we talk about, the last picture about the doctor and the engineer, I feel like there should be a lot more maybe stakeholders there, where the conversation should be opened up to and considered as equally important stakeholders in this debate. The people, the patients on whom this is being experimented, social scientists who are critiquing the impact of these technologies on the lives of people, etc. So what we can do is now open up the floor for conversations and discussions. How long do we have for this? We are running late by about 50 minutes, so another 20 minutes. Okay, alright, so maybe for 20 minutes, we can take we'll take 3 questions and then have the speakers respond. It doesn't just have to be, I think, limited to questions. Even if someone has comments or something else to add to the conversations that are happening, we would love to hear that as well. So yeah, if
couple of comments. One is I heard that different things about how much we trust the data that frontline workers are putting in. Suppose the data said that we actually have 60% stunting instead of 40% stunting. Would that be something that health systems would be comfortable sharing publicly? Right? That seems like a complicated question to ask. Second, very brief question about the medical research discussion. Let's say there was a whole history of data that points to a particular treatment, but suppose that treatment is totally wrong. Right? This is the Turkey problem. Right? Turkey survives for 300 days, so it thinks it's going to survive Thanksgiving Day, it dies. So we know that in diabetes and many other areas, new innovations come in because somebody thinks like a crazy person. So how does that crazy person get? From a machine learning perspective, if you use machine learning to derive insights, is that a complex challenge innovation scientists and physicians will face in the future?
I want to take context one level further and by giving an example, I'll give an example later. What I want to ask you is, do you also build rules by which these data are collected, or actually initialized into your models? The reason why I'm asking is, and I'll illustrate that with an example. Imagine a credit card company which has a rule that they will give loans only to people who are 20 years or older, unless the 20 years and younger people have rich parents and their parents are known to the manager. Now this is a rule. Now this data that will come in will only have data from children who are 20 years and only have 20 years and younger people who are either having rich parents and are known to the manager. Now in this case, any machine learning or AI algorithm will tell that all 20-year and younger children always return their loans, which is exactly the opposite of what we should observe. So what I'm trying to say is that since all healthcare data actually comes from rules, when do we collect data? What are the indications in which a person needs to undergo a test, for example? So unless we have those rules as built into the context of the model, I think there is still a huge potential for the models to be biased by what data they are seeing. And probably later I can also give something on how we think that basically that also leads to health inequities and needs to be solved. My second question is to Surajit, and that is, you brought up this question of who needs to be told. So to me, isn't that a question of, again, a context? Should we be looking at positive predictive values? How much is the prevalence of the condition in that particular setting? It might be different in the US, or it can be different in the Indian settings. And then the choice of screening versus the validation tool. And then it comes down to model performance indicators. That these are my model performance indicators, and the numbers needed to treat with this particular test in question is, let's say, X, and the positive predictive value of the test is, let's say, Y. And the prevalence of the condition in that case, when is the case that you anticipate that information like that could go wrong while it is being delivered to the doctor? I'm not talking for patient. When the healthcare delivery person is being informed about it.
I just wanted to thank Ashish because I come from the grassroots and I understand how important AI would be for the grassroots. And what he did was a very good thing. He first understood the grassroots issues and then he came to AI, not from understanding AI and then going to the grassroots. So that was a very intelligent thing to do. And I just wanted to put a question, like, we are talking about AI from the perspective of policymakers, but are we really talking about the stakeholder, the patient? What is the involvement of the patient in this? And we are talking about the importance of the data, that is the patient, and he is not at all involved. So I think that is the most important crux we all are missing here, and that should be, I think 50% of us should be patients and 50% of us should be us. Okay, so that is second point. And the third point was to Dr. Surji. That was about, again, you're talking about the scalability of the data. Okay, and here we are still not even having the manual data entered properly. Okay, so we have to understand the issues from all the levels first, and then go to the level whether it should be a child or an old woman. So that is where I'm coming from. Thank you.
I will answer them in the order I remember. I think your point on the data, let me take it first, and there was another point on the data about stunting and how to deal with it. So the point is that yes, data is based on rules, but what we have tried to do is that mostly the procedures and rules are well laid out in healthcare. Okay, there may be exceptions, and I don't know entire healthcare scenario, but the work that I was doing, they're very well laid out. When should the height be collected of the children? It is done as per a calendar. If it doesn't do as per that, then there's an alert raised. That also system provides. All the systems provide. when should the weight be taken, birth weight should be taken only within 48 hours, all those things are codified. The demographic family survey gets done only once a year. Okay, so all those, yes, it is rule based, but unless we find any particular reason for not or changing the rules or questioning the rules, I didn't feel the necessity of doing that. So maybe I am wrong, but I fail to see how the model will be inaccurate with the given rules that we are trying to follow, which are the well laid out, well set procedures. The problems are not about the data rule. The problems are those procedures are not followed. So a weight of the child, instead of getting taken every month, it is taken every third month, then there is a problem. I have an issue with it. That's why when I often find a discourse that behind the technology, the next thing that we discuss is data. And what we miss out is the process. My feeling is process is actually more important than the data, because then you can situate the data. Because unless you know where your data is situated in the whole ecosystem, which is a function of the event in the process and the function of the stakeholder in the process. If you have not nailed down the process, your data interpretations are going to go awry. So I think that's a little bit on that one. I don't have any more comment.
Exactly what I'm saying. That do you model the process as well as
Yes,
the part of the model?
Exactly. Our thing is first the process, right? So child we track from birth to 5 years. Every case is managed. The moment he is detected as child malnutrition, a case ID is given and that case is tracked. Mind you, I must admit that while our system is getting piloted in the Anganwadi center, it is getting piloted in the tertiary center. THC we have not been able to push through, so we are still relying on SMS and some manual data because again it's an adoption issue. But that is the whole game, that we have to tie in the process end to end. So on that one, and sir, your point on stunting and the thing, how much, again that's a matter of, you raised it in the context of trust and evidence that if the Anganwadi based on the data which is fed in by the Anganwadi center, a stunting thing comes, what should we do about it? See, my opinion is like this, that and I'm taking a solution-centric view, that every solution takes iteration to mature. Okay, and we have mentioned that even in the AI, Dr. Shiv Kumar also mentioned in the morning that today you cannot trust AI, the algorithms are not that mature yet because that much intelligence has not been. Same thing is about data. The first time it is rolled out, first 6 months data is not worth trusting because the processes are not understood well, the Anganwadi worker has not been trained enough. So it is an iterative process because human beings are involved in the whole process. But are we managing the process in such a way that after 6 months it becomes trustworthy? Partly because we have built the capability into the system. We are doing without intrusion. Our design principle is that evidence should be collected with minimal or no intrusion. Because if you put intrusion that somebody is taking photograph and she is doing the weight, then it's a different matter. But anomaly should be detected by the system itself. So if within the time period we can do that, I think over a period of time it will become trustworthy. So the answer is yes and no. Immediately, I think we have to take it with a pinch of salt, but after a period of time, we should take it with an accuracy. And I'm forgetting your question.
I said that first I wanted to compliment you that you had taken the intelligent way of first going to the grassroots, understanding the process, then coming to the AI. So now I just wanted to ask you was that how was it?
As an experience.
Yeah, and even as while going up to the level of AI, how did you manage it?
So we did a pilot in both rural and urban areas. Okay, and we realized a couple of things. It's a little bit of mixed because everybody is not amenable in the same way to the technology. But the moment we talked of trust, the solution provider also has to get a trust into themselves by the field workers or the grassroots workers. Once they start trusting you, because without taking any phone or even notebook, our team was just sitting with them whole day. And we have cases where the Anganwadi health worker has cried on the shoulders of one of the lady team members that no, look, this is the kind of problem we face. So that's what makes it an action. Then after that, you say, can this application, if I do this for you, will it help? She said, no, not that. Do a little bit different. That's how you actually build over a period of time. Now, of course, you will only have a sample to work with. But then after a period of time, you realize that your solution is taking shape in a way so that it will get well adopted. Because
What
it has
is the
come
length
from
of your project? How long is it?
See, we have just completed about a year.
No,
Okay?
how much have you been given by the government?
Let's not discuss grants here.
No, I mean the length of the project. I mean,
Huh,
you get
so-
a 2-year project, you get a 3-year project. How long?
Right.
is the
So
project?
it was, to begin with, it was 1 year to be able to pilot in a specified area. Now that area has been expanded a little bit because government wants to experiment a little bit on the integration. What they are excited about is not the app. App they will get from central government also. What they are excited about, because of that, the whole streamlining. They were having two departments were not able to match the data about a
Right
child.
now, is it open-ended? I mean,
No. So they'll give it extended by 6 months more. So by December.
So
Yeah.
1.5 years.
Because that file, because of whatever is happening in Karnataka, has got delayed. So it will get it by December, and we'll wrap up the whole thing.
Thank you so much for the responses. Before I move on, I just wanted to ask the other speakers if they had any responses to the current questions or.
You asked about whether if good data starts coming in, is that what you meant? Will that change be acceptable?
I mean, often, very bluntly, people in government don't want to show worse data, right? That's what I meant.
Exactly. So what happens is that manipulation happens at the lower end and the top end is happy with this. So it's a very self-satisfied system. So, but if there needs to be a change, it has to happen from the top. The state government will have to push to get the good data. They will have to respect that change of indicators that will happen. They will have to appreciate that. And only then will we see a change. If that doesn't happen, the Anganwadi worker, the Asha will probably not want to make those changes on her.
What is the best predictor of intelligence? Does anyone know this? This is a famous case. What is the best predictor of intelligence? So,
Adaptation.
sorry?
Adaptation.
Okay. So Facebook did this study, and they found that preference for curly fries. Does anyone know what a curly fry is? Like, if you go to America, I think Popeyes has it, but they're these like long fries which are little chili. So preference for curly fries is far more predictive than ability to do a maths test. AI is weird. So I don't know if this answers your question at all, but AI is weird in that the things that big data can do may not be things that are easily explainable models. In fact, are not. I mean, this is the crux of the difference between Google and Yahoo, and why Google succeeded, which is that Yahoo tried to make it explainable models, their search engine, but Google just threw essentially an AI at the backlinking problem. I think that sorry, you've achieved your goal. I have forgotten everyone's question, but so please ask me the question if I haven't answered it. To address this idea of can you make a series of positive predictive value, sort of 2x2 boxes, if you will, of sensitivity, specificity between every given presentation, every given treatment, and extend this through a whole system. Well, think about what the Bayesian joint probability is of all possibilities in the world. And you realize that for a human to develop this is actually a impossible job. So, as an example, when I was in training, the best way to detect a cardiac arrhythmia was something called a Holter monitor. Some of you may know what this is. A Holter monitor in those days, it was something about this big. You would carry it around with you for 48 hours. You'd have to sleep with it, and it would be connected to your body. That gave you some predictive value on how whether the person had a cardiac arrhythmia or whether they were going to die. What is the best source of that data today? Fitbit. So Fitbit has, I think, 1.4 billion. I won't be able to say exactly the thing, but something that is I think they have 1.4 billion times the amount of data that the Holter monitors had across the world, ever. And although Fitbit only collects a subset of the leads that a hold-to monitor does, the predictive value, because of this great huge amount of data, is remarkable. So you may find that, we're talking about rules of collecting data. It may be that, I think it is, that you do not actually need people to learn how to, you showed an example of, like an AI deciding what the true height of a child is versus what the constricted height of a child is. That you don't need rules, you don't need to define what the process is. But there are data points, such as if the person moves left when they come into this door versus going right, which is very predictive. And when those insights come up, when AI comes up with those insights, it may be able to first detect it better than a human can, because a human's brain cannot detect all the variables that are necessary. But also that once it detects it, it'll be able to push it through the bureaucracy, if you will, of AI. The idea that if someone has a good idea as a human, to make it widely accepted is a hard problem. Nassim Taleb goes into this. But an AI may be more willing to accept the positive predictive value of a good new idea, such as curly fries predicting intelligence, than a human bureaucracy, an AI bureaucracy. So, sorry if I've not answered the question, please reiterate it. I will be happy.
Okay, so we just have like 2 minutes more, so we can probably take one final question, but I'm sure we can continue these discussions over lunch and through the next session here. Whenever we are working, say being a statistician, I'm working on a very huge big data, you can say, but longitudinal data where we are following the children right from the birth being, say, 25 years of age. So what I could see that yes, this process is always important, then the person when it comes to the data. And I want to bring in one more point that whenever AI experts are working, they should not work in silos. They also need to understand the interdisciplinary approach of, building of the model. That's the only point which I want to bring in on table. So definitely that Jamana has gone when you are, sitting and working in AC, sitting in one in chair and then not understanding what data talks about. So you also need to understand the domain where you really want to apply those models. Then only that model can work in reality. So definitely process is very important, but you also need to have that kind of interdisciplinary or say multidisciplinary approach for having this kind of tools and techniques applicable in the domain. Thanks. Any other questions?
Yeah. So it's just a couple of quick points. One is that in a lot of the work that's happening, and especially through in the context of technology, the people on the ground are seen as objects or subjects of the exercise, and therefore things are done for them, like they are, and it's the goodness of our heart that we're doing it for them. And many technology projects are being promoted on this, that we are doing it for the poor and therefore it's all right. This is not about you. But the question that I have for you in that context is, you're right that many things are offered as solutions when you don't know they're solutions at all. I wondered if some of the systems that you adopted as part of your solution, did you test them to see whether they were solutions or they were just other problems masquerading as solutions? That was one. The second thing is, you were saying about tracking these children. I just wondered whether you had anything built into your system where there'd be a deletion of erasure of this data. Because after a certain point, it's no longer necessary to follow to see whether they are stunted or not. They grow past their childhood. So is there anything at all about the finiteness of this data and who will have access to it and what you do with it? And whether you saw that there was a link between this kind of tracking and surveillance. And I wondered too, in your facial recognition, when you were saying that it keeps changing, so every day you take their photographs and things, whose consent did you take and what is the kind of system of consent that you followed when you were taking these photographs time after time? And just one comment which goes back to the earlier session, which is that, and it came up here too, it's not just about jobs. Actually, a lot of technology is now coming in saying that it's going to result in disintermediation. So all the intermediaries in these systems are going to be divested of their responsibility, while they'll be allowed to use the technology that's being brought in to take on the responsibility. So that's being done in civil administration, for instance, where the administrator is no longer responsible, the management system is. And I'm wondering what that means for doctors. It's not just about losing jobs or whether you're going to have any other things. In judging, it's happening. You know, in the US, you have algorithms which are saying who are more likely to commit crime again, and therefore what kind of sentences they should be. There is a debate going on about this, but in the criminal justice system, it has entered. So I just wanted to put that in that, you know, when we're thinking about this, it's not just about losing jobs. This is a different time from the time when automation was brought in. This is about control shifting over. And a lot of what you were saying, I know it's unintended, but it seemed like control over populations is a good thing. We need to know where they are, what they are doing. It's also assuming a certain kind of infantilism in the poor and in the health and otherwise vulnerable. Like mothers wouldn't understand, they wouldn't know, so we have to take over. It's a new form of paternalism that technology seems to be introducing. I just wondered if you'd had discussions on this before you arrived at.
I have a couple of questions. I think I just take off from what these last two presentations comments were. I think we need to bring the issue of health system at the center. Because when she said that there were silos, the silos is not only just related to various small programs, but the way physically the systems are organized. Public sector, private sector, various kind of programs and all. And I think that was one of the major reasons why we never built a health system in India. And it seems that our preoccupation, the kind of choices that we are making for developing technology, is also showing our ideological choices or the moral choices that we are having. Because talking about ethics in general, at a very micro level is fine. But talking about ethics at a bigger level, about what choice we are making and how we are looking at the health problem is very, very important for me. Because the public health can also get reduced to just looking at few diseases, epidemiology. So, you have a tuberculosis program, you have malnutrition program, you have this, that and all, and you keep creating various kind of stuff there. You may be able to succeed, like as we did in polio, but that did not lead to any kind of system standing in India. It's just remained, system actually became weaker and weaker because we never looked at the larger part. So I don't know how you are going to apply the AI in system building on a broader scale. The second is that we are so preoccupied with the problem and problem solving. We are forgetting that one of the major work of the health system is to care. That's what she said, paternalism, what I would say that a highly masculine way of looking at the health problem, rather than saying that, well, in the doctor-patient relationship, it is very, very important that how we as a system, we care for the people. And do we care for the people by just looking at the diseases, or they are looking at them as human beings? So the larger issue, I think that getting totally obliterated in the kind of the programs that we seem to be taking. The last thing is about data, both general data as well as research data you were talking about. The whole debate on the Cochrane at the moment and the kind of split that has come about after Peter Gonse was sacked from that. It shows that data can be manipulated at different levels. You can say that, well, how we collect data and fudge data at that level is problematic. But even if you have good data, the data users are very important. And who are these data users? Do they have really good of the society and the people whose data they are? It's like drug companies getting clinical trial data, and how do they use it? How do they manipulate it? How do they use a ghost management system in order to ensure that their products actually really go into the system? Those areas are very, very important. And for that, do you also have inbuilt system? Because you say that, data should be shared with various kind of professionals and government departments. But what about the people at large? Are this data available in public domain? To what extent, as she was saying, that this data also protect the privacy of the people whose data they are? How long they are kept? Are there any norms, set up. I think the whole transparency about management of the data is important. Otherwise, I feel that we try to perpetuate the same elite system that was there, and that way, by getting more and more control over people's lives, we try to manipulate them. I think that's what the AI will become. Instead of a tool to do better medicine, it will become tool to control, people who are on the other side of the fence.
Doctors generally are liable for mistakes they make, etc. So, would let's say AI service provider would they accept taking the liability for a wrong diagnosis? I'm someone who kind of abhors violence, but just to make it more picturesque, who does the patient's relative beat up when something goes wrong? Yeah? So that is primarily the question. So to what extent will you be able, for instance, if there is an encephalitis outbreak in Karnataka, should you be held liable? So that is I'm still not clear about that bit, because with ethics, there is something called liability. When you buy a car, for instance, the famous Ford Pinto case, where it just caught fire, and the Ford was liable; it had to pull back. The Boeing case, classic case of artificial intelligence. Two planes crashed because the pilot didn't have the control over the inclination of the vehicle. So the liability bit, I'm not still clear.
I'm no lawyer. There are lawyers here, but I think there's two kinds of liability. One is legal liability, and the other is ethical liability or real liability. The legal liability is something that I understand. Again, I'm not a lawyer, so please. That that if you type, as you said, if you type "I have a headache" into Google, and Google says you might have lung cancer, and then you undergo like a lung reduction surgery and you die. Google, by Indian law, is not legally liable, because the person who is liable, who perhaps did the surgery in the example wrongly, is the human being, the doctor. And so the platform on which somebody else posted something. Let's say there's an article that says that if you have a headache, you may have lung cancer, right? So the platform is not liable for that. I think this is recent law that was read down by the Supreme Court. That's some.
But you're right about it.
Okay. The ethical liability is a much deeper and harder problem. The person who was killed in Texas by the self-driving car, she was a homeless lady, right? She was walking across the street and against the traffic light. If I understand the example correctly, the self-driving car hit the lady. Now, if a human being had been driving that car, that human being would not be liable, ethically liable, also, because it's Tesla. Because that Tesla applies to all the now millions of people who have interacted with it, because it's one entity, that the name of Tesla is now liable. But that human being in the counterexample who hit the homeless lady walking across the street against the laws, that idea is not, you can't hold all human beings liable, right? But you can hold one entity, which is Tesla liable. So I think the ethical liability, the legal liability is fairly clear under Indian law, but that doesn't say so much about ethical liability. I'm sorry, I've forgotten all the other questions, but please reiterate them as well.
First of all, those are very relevant points that you made. So I have very honest confession to make. So look, our solution will not be perfect. No solutions are perfect. I think that is not a good, fair way of judging also, because what we have to see is it directionally in the correct direction. Whether it's paternal or the way you took it, maybe to a little extent. But then, to be very fair, we did go through multiple kinds of options that we had on our plate. which we felt were practical and feasible. This did not look to us paternal. Maybe some women may find it like that. Okay, I'm not saying it is perfect, and then the people are also different to each other. Some women actually were quite happy to use it. If they are getting the good advice at the right time through SMS, they are pretty happy, because then one woman told our team that when they are pregnant, because they were a migrant family, by the way, they don't have any support system of an elderly woman in the house. Husband is away and is a domestic abuser. He said, I would rather have a company of somebody and advice on a constant basis. Okay, so there are different ways. So I'm thinking maybe we may label, because anecdotally I'm quite sure my system will get proven wrong. This will not. But the point is, yes, we felt that we have taken a step there. We will keep on refining it as it hits more people, and then we'll see that whether it can be made more inclusive. That was the point that I was making. Second thing is about data privacy that you raised the thing. That's a question that I don't have a complete. What we are trying to do is, and this is in consultation with the government, that's not my point, because the school system now wants to integrate with this, because we have an alliance system, and they want to maintain till class 10th the data, because a lot of immunization and some tracking happens there. Okay, now that can be called surveillance, but I will have a point on surveillance part of it, because my view is that data equal to surveillance is a very hard mathematical, rigid mathematical formula. But that is what the point of view. I will wait for a good regulation that should come out, because Shri Krishna report also is now lying for 1 year, and I have a feeling that we are missing out the true discourse on privacy. I went through maybe a book about a year back, because I was exploring a lot, and right now I'm in formulation of a data governance strategy for some other project, because data governance as a field is just about actually evolving in terms of people are understanding the protection aspect to it, the privacy aspect to it, the surveillance aspect to it, and trying to put up a solution framework. That is not all technology, by the way. Some of it will be process, some of it will be that. But that particular thing is coming. I remember a 2006 paper by a person called Daniel Solow, because what happens is whenever there is a data collection, we jump to surveillance. But there is no one taxonomy that people are actually using to differentiate and analyze the data and the privacy issue. Daniel Solow gave good 5 main parameters, and then I think another 15 parameters to define. It may not be exhaustive because it's 2006, but for the first time my mind lit up. I said, look, this gives me a framework of understanding. Surveillance was only one of those 16 things. That when I talk of, say, Aadhaar, I will look at all the 16 Aadhaar in terms of intrusion, in terms of aggregation, in terms of usage, in terms of trust, in terms of whatever, where did it stand? Because then I will be able to talk meaningfully in terms of what should be corrected. Otherwise, what happens is these become very generic labels. I feel about what you are saying, but for me, that feeling is not good enough to act. The only action I can do is to scrap the solution, which in my opinion is also not good. So where do I stand? Nowhere. So I think it's important for all of us in this room and others also that a discourse which is more objective and more detailed should be evolved. Because right now, moment data is collected, you say privacy is being hurt. Maybe, but then we have to look at what are the options, what are the better alternatives, what are the best, worst alternatives, and if it is not a good alternative, why not specifically? Then I will understand that part better in terms of being able to do something about it.
No, I think Dr. Sethi had raised a point that a lot of data has always been collected, but it was de-identified data. This sort of specific tracking of individuals is problematic, and I think across the world people have had problems with it, and they have raised very valid issues. So to say that we will think of a regulation in the future, no, we have to think of a regulation now, and the problems are now. And de-identified data is one thing, and storing that is one thing, but to have identified data where I can track one single individual from the time the person is a baby, when the person had no right to give consent or not consent, and then track all the way up to class 10 now. Next you will say, I also want to track them till they finish their graduation. Then why not track them while they are also doing their job? There is a problem.
No, there is a problem.
So she's only saying that we should have some sort of a moratorium saying that if you're finished looking at them and you have achieved the target, which is basically that cure them of malnutrition, then maybe you need to delete all that data.
No, data will remain with us. Anyway, it is all with the government thing. But so there is a. I get it.
Which is why I was saying 1.5 years.
My project ends. Government first doesn't end. That's what I'm saying. Don't link it to my project duration. The linkage. Now the ownership only gets transferred at the end of the project. That way the app should also get deleted. No. What I'm saying, the point.
No, but that's the reality. That's exactly what I didn't want to go there. But what happens is a lot of things which you suggested is basically only are going to last as long as the project till somebody else gets a consultation and they suggest another solution and then that gets. So we know this is what has happened to most of the solutions that we've seen work in health space because new people come, they keep suggesting solutions, they keep getting implemented. The moment the government changes, that is dropped and the new consultant comes in and the new solutions come in.
But there is a difference that a lot of our work which is foundational and not technology related. That means no app, no AI, nothing. Just having a single ID for both. That is agreed by circular. Okay, that is a policy change. Okay, that there will be only one way of identifying. In fact, that is a step forward. Why should have multiple? Identifying a person itself might be bad. Identifying in multiple ways may be even worse. So at least that is a step in the right direction.
There is already a mother and child tracking system from the central.
So MCTS has been changed to RCS. We are adopting the same
how
idea.
many systems will you keep changing?
It's already changed. It is already changed. MCTS to 28 states are already onto it. MCTS has changed to RCS, and we have adopted the RCH ID. We don't want to create a new one.
Perhaps it's our system is used by a government hospital. The NIC is an entity which provides services to the government hospital, technology services. If medical data is digitized in the government hospital, who owns that data? Well, again, I'm not a lawyer, but under Indian law, it's the patient.
Yes, actually right now there is no such thing, but what they did without consulting immediately.
There's some regulations.
No, in 2012, they brought out a policy document which said whichever department is holding it owns the data. Where on earth they got
They're the custodians.
like that given those.
They're the custodians. So the word uses custodians, whereas the owner of the data.
No, I'm sorry, it says ownership and property. Please see carefully.
Because just a week
it says
back,
property of the department.
Sorry, in the IT Act.
No, just a week back, the entire NHS health data has been absorbed by Amazon. And somebody protested. They said this is available for free, so why are you protesting now? It was anyway open data. So she's saying NHS owns that data because that is where the care is provided. And now the debate is why did they transfer it to the private sector? They could have used it by NICE to get that data.
But the latest amendment to the other act is to enable the transfer of the data to private companies.
So this is just last week. The entire NHS
Actually,
data is actually
it wasn't addressing your project particularly. It was to raise the question that when we are devising a solution, we might look for something that's but the other solutions that we are absorbing into our solution may be hugely problematic. And whether we are looking at that at all, and then when we use terms like tracking and we are talking about every day I take a photograph because one day it's not enough, then there's a whole host of ethical and other questions that are.
But photos we anyway delete just to set your mind at rest.
Not begun with this. I'm just saying, see, you said process. This is part of the process of thinking about it. So it's not really attacking your project.
No, I'm basically
saying
it's a relevant problem.
You helped us find those other questions, locate those other questions that are coming up, which we need to think about.
There's this interoperability idea, interoperability of data, right? And it's not clear that this doesn't exist right now. You could imagine all the digitized data on the world that's connected by servers as just data which has a certain set of operable interfaces.
But you can't look at the interoperability that has come in the banking system where your money is no longer, there's no confidentiality there. To see how that reflects on what would happen with health data. We'll look at it. Right now it exists in India.
Absolutely, but if you look at, for example, the difference between the UK and the US has tried to do interoperability for decades now. Since 1995. They have gotten nowhere, despite billions and billions of dollars being spent on it. The UK has a huge amount of the data that is now, as you said, I'm not sure it gave all the data to Amazon for Alexa. I think there's certain things that Alexa can do, but the reason is because the US data is all, as you said, it's all siloed up. It's all in, Mass General Hospital has some, the VA system has, and those don't talk to each other. So India.
Sorry to just cut you off halfway through. Please complete your sentence. But I just wanted to remind us, in the interest of time, to just wrap up this quickly.
Talking about liability, and you say complete your sentence.
Apologies for this, but so that we can have the rest of the session go according to schedule as well. And I'm sure we can continue these discussions over lunch as well. But please do.
India is a lot more like the US. It is much more siloed, and that may not be altogether a bad thing.
No, but that's because it's a fragmented health system. In the UK, you have a single payer system.
Yeah, that's
Can I
share? Can I request the chat to share? You all
if you could just wrap it up in 1 minute, that would be great. Thank you.
Maybe 30 seconds.
Even better.
What actually we do is, I'm going to share it to all of you because we are going to soon publish, but this is a good case study what we have. What we are doing in public health space, which really the country wants. Along with the Tamil Nadu government, the data in the public health space, especially disease surveillance, was not well recorded. So we established electronic disease surveillance for the past 3 years. And we had nearly 1,400 data points of confirmed dengue cases the past 3 years in one particular district, which are all geo-tagged data spaces. Geo-tagged, which I am spelling, is that in terms of nearest habitation where the dengue case has happened, not the exact house. Okay. And with that, we developed a machine learning model which predicts the dengue incidence. So what I'm trying to say is that what actually the country really requires is more burdening in this country is that the dengue burden. What the system's understanding is that to tackle it, the Tamil Nadu government came up with a kind of a query, and we jointly worked with National Institute of Epidemiology, jointly worked with that, we developed this model, and now it is being integrated with the disease surveillance system. It is creating solutions where we are acting upon the evidence, and this predicts the dengue incidence 7 days before. So public health preparedness are well prepared. So that's one thing which I'm sharing. We'll be soon publishing it. So that's one thing which I'm trying to share.
Thank you so much for all the comments and the great discussion.